Hey, Jim, I posted those on the discussion board, but I did it at the start of the meeting, so they probably would not have had time to read it in advance of this meeting. I was waiting to see if we got any more questions in.
I'm not worried about it. They can read those.
Yeah, so Mike, I can let him know, Mike, that answer will be on, is actually already posted in the discussion board.
Yeah.
There's a 30-minute delay when I post it on there to when it comes up, so it should be popping up in your email shortly on selective tissue tension testing.
Oh, selective, yeah. Somebody asked me about that. I saw that earlier. You're going to go over selective tissue tension in detail in the classroom. Mm-hmm. Okay. Somebody's asked about neurological stuff. I answered the email, and you're going to get a video on Friday. One of the videos is on neuromeningeal testing in general, and then I'll do a specific one for the lumbar spine and the cervical spine and thorax, closer to their modules.
We haven't covered obligate and non-obligate loss of function. Do you want to address that for a second, Jim?
Yeah. Obligate, let me do this in, okay, let me give you an example. Segmental dysfunction. Segmental dysfunction, the typical patient's illness script on this is moderate pain, moderate referral, episodic pain, and so on. Ask me that in a second. I missed that, but ask me that in a second, that cancer. Okay, so a non-obligate functional loss, which means you can do things, but you choose not to do them or to cut back how much you're doing. The other term for this is, and it's the one I tend to use now more than obligate and non-obligate, is elective rather than non-obligate. You elect, you choose not to do things or to curtail exactly how much you're doing because you know there are consequences later. Obligate functional loss is you have no choice in it. So if we look at a disc herniation, there is most certainly obligate functional loss there. And the obvious functional loss is not being able to sit, because they can sit. Not for very long, but they can sit. What they can't do is, okay, what they can't do is walk. They limp. They do not walk, they limp, and they can't walk. Now that is obligate. They are obligated not to be able to walk, if you like, but it's not a choice. They can't do it. Now, obligate functional losses typically, with our patients anyway, come with increasing pain. So the more severe the pain, the more likelihood there is obligate loss. The less the pain, the less chance of it being an obligate loss. So if I have a segmental dysfunction that is atypical and the pain is severe, and you do see this, they get confused for disc herniation, because the other thing they get because of the severity of the pain is obligate functional loss. So rather than looking about this patient who has this very severe pain, and referral is also about the severity of pain, at least in part, more referral than you would expect with a segmental dysfunction, plus obligate loss, your hypothesis isn't a biomechanical dysfunction, your hypothesis is probably a disc herniation. And that's the route that you'll take, and you'll end up disproving that eventually. And then you'll have to come up with another one. As soon as you see atypical presentations of a condition, and those atypical presentations are mimicking another condition, then it makes the whole diagnostic process much, much more difficult. And you're much more likely to be wrong at the end of it than if they're typical. But that's life. Cancer. Cancer of what? So the question came up is, you were taught that cancer is a contraindication to manipulation. Cancer of what? If I've got
that was me, Jim. That was me asking that question. I was just wondering, because I remember through school they always talk about, like, oh, all the contraindication list always has cancer on there.
Yeah.
But, like, is it?
Depends on what cancer we're talking about. If I've got a patient with,
say, for like an ankle, if they have.
You're breaking up there, Alton. Okay, I think I've got the question anyway. So if this is bone cancer and then yeah, I would agree completely. You do not manipulate it because you have no, and it may not be in the bone you're going to manipulate, but it may be. There's no real percentage of doing this. If this is cancer of the pancreas, I'm not sure. It depends on whether it's there or not. You've got no idea about the spread. If you've got a cancer that doesn't metastasize, then no, there's not a problem with it. It really does depend on the cancer. Presumably, the cancer's been identified as cancer. Yeah. So you should be, if I had a patient walking like that, I'd want to know exactly what the cancer is. I'd go to the textbooks, as I don't know, find out how it spreads. Does it metastasize the bone? And if it doesn't, I haven't got a problem with it. I actually had a woman come in. This is a second go round with endometrial cancer. They sort of did something first time, they didn't get rid of it. She had a recurrence of it. And she was sent to me by a doctor with a diagnosis, and the leg was just swollen up because she also had a femoral vein thrombosis that wasn't moving. She had a thrombosis in the vein, and they were trying to get rid of it, but they reckoned that was going to be another 6 months before they managed to shift that. So she was getting cancer treatment, she was getting treatment for the thrombosis, and they wanted me to do something about her leg. Now the leg was about that wide, all the way down to her foot. So one of the things I did was I was thinking about doing IFC amongst other things. So you go to the textbooks, and in this case, I didn't go to a medical textbook. I went to the IFC books, and they had a definite no. Do not put IFC through the cancer site when it's endometrial cancer. Now, I could have put it up and down the legs, but I talked to her about it. She didn't want it. I'm fine, didn't do it. What we did do, though, was I basically put very tight elastic bandaging all the way up and down the leg, had her elevate the leg, shift it up and just do stuff in it. Got to do that at home. This is with a thrombus as well, mind you. Got to do that at home about 4 or 5 times that day, and then come back and see the next day. And everything, the whole leg had gone down. The lower leg had really gone down, the upper leg about 50% over what it was. So it's not really great to get overly concerned about cancers. Find out what you're dealing with. All right.
Yeah, it's really a judgment call.
There are other treatments you can do as well. It doesn't have to be manipulation. There's other stuff. I really don't like mobilizations, to be honest with you. I had probably about $20,000 worth of machines that would reduce pain. For me to stand there for the next 20 minutes doing grade 1, grade 2s seems to be a complete waste of my time. And the machines tend to do a better job and a longer lasting job than I can do. So I tend not to do that. But that's personal preference. Sorry, Dave.
No, I mean, I would mobilize. And what I would actually do more specifically is, and what I liked from this is I take away the biomechanics that we're going to learn in the lumbar spine and thoracic spine, and having a keen understanding of the biomechanics, if you can find the restriction that you want to treat, you can oftentimes guide it through. I find that even now I manipulate maybe, I have to thrust maybe 20, 30% of the time, because by the time I set it up mechanically, the joint's generally going to go in most cases. There's those that we need to thrust with. So the cancer patient, my first line is going in there, and if it's a rib and I want it to, okay, it's stuck at the costotransverse joint, I'm going to work with that a bit and see, can I, through alignment, rotation, movement, get that joint to free up without a thrust manipulation? Would be my first line with this. So
okay, let me tell you about
biomechanics. That's manual therapy, by the way. Yeah. So when you say no manual therapy, that's manual therapy.
Yeah, so it's not manipulation.
We're referencing
about a patient I had. This was a 65-year-old woman. I knew she was osteoporotic. She was very fragile. I bent over her. I was going to do specific traction on the lumbar spine. I bent over on her. I used to wear one of those like jackets, and I swear to God, my jacket touched her rib and it broke. I didn't even laid a hand on her and her rib broke. Fortunately, she went, "Oh," I said, "You're all right." She went, "You broke my rib, but that's all right. It'll be better in a few days." So it's not really what you want. I wouldn't touch somebody with fragile bones. In all honesty, I wouldn't do it. I don't get anything out of it. They're paying me $20 or whatever it is per treatment. And this is my $20 rule. I just don't get enough money to take that risk. But that's personal. You do what you want to. But cancer in itself isn't necessarily a contraindication to manual therapy. Marissa, what was your question?
I was going back to progressively worsening pain. So if you're seeing somebody and they are progressively getting worse, the doctor is aware, has seen them, but the doctor is not concerned. Do you continue seeing them? At what point do you maybe ask for a second opinion? I mean,
What's your diagnosis?
The patient came with sciatic pain. So it's very vague, but sciatica was the beginning of the diagnosis.
All right, let's do this then, because you're not going to ask this question in a few months. Sciatica isn't a diagnosis.
Say that again.
Sciatica is not a diagnosis.
Yeah, okay, yes.
So you've got to have a diagnosis. So if I've got a disc herniation that's causing leg pain, whether it's radicular or non-radicular, I don't expect to see that pain getting worse after about 4 or 5 weeks. It should have peaked during that time, providing I'm not doing stupid shit. Yeah.
Right.
They're not aggravating it every time they do something you don't want them to do. So providing they're complying with everything else, that pain should stop getting worse in a given amount of time. If it's still getting worse at that time, it's probably an atypical disc, but it does need looking at. So the question is this getting worse? Because your problem there is, if this is getting worse and it shifts a bit more median, then you're likely, yeah, I know, Jenna, then you're likely to have this shifting towards a cauda equina problem.
Yeah.
Yeah. Jenna, you can't be responsible for idiots. What you're dealing with is what you're trying to do is not control the patient's behavior, because that doesn't work. You give them clear cut what you can do, what you can't do. And when they come back and say, I'm worse, you say, did you do this? And they say, yeah, you laugh at them. That's probably the best tack I've ever made. But you don't take it out yourself. But you bring that into your calculations. Is this getting worse because they're a moron, or is it getting worse because there's something intrinsic that is getting worse?
And if it's truly intrinsic, I'm not worried the patient at the time, I wasn't worried the patient was doing something stupid. It's more, you know, what time do you finally say, like, no, I need you to be seen? I mean, my 2 rules of thumb are usually, if you can't reproduce the pain, that's a problem. And then if it's worsening, that's a problem.
Yeah. So at the very least, if you're treating them now, like if this is in your history, it's getting worse and worse and worse. Mm-hmm. At that point, what you're doing should stop that from getting worse and worse if this is not a progressive disease. Yeah. Yeah. So you should be able to stop that getting worse and worse. It means that your treatment's not working. So either they've got a condition that you have misdiagnosed, or you're doing the wrong treatment for it, or you're doing the right treatment wrong. So you've got some options. You can ask somebody with more experience to have a look at it for you, mm-hmm. or you can fire it back to the doctor and tell them exactly what you found. Yeah, but yeah. You've got to have the diagnosis to be able to do that. You have to be confident in your diagnosis. Actually, you know, when you make a diagnosis from your assessment, it's a provisional diagnosis. It always is. It's provisional on your treatment that's planned from the diagnosis actually working. Because if your treatment doesn't work, then there's a really good chance that your diagnosis is simply wrong.
Makes sense. Yeah.
Right. So, yeah, almost certainly if it's continuing to get worse, you made the wrong diagnosis, or you're trying to treat something that is going to get worse.
Yeah.
I know you've got 2 problems. You've got 2 problems that you really can't control very well. One is the patient, who could be a complete idiot, and the other one's a doctor, who could be a complete idiot and all. So you've got those 2 factors chewing into your practice.
Yeah. Thank you.
Okay. What came up there? I missed out on the chats.
There are a bunch of questions on the chat. I've copied and pasted them. So the ones I don't get to on the chat, I'll post on the discussion board.
Okay. Oh, you got 36 questions there. Okay, that's always an interesting one. Once you tension the tissue, are you getting a cavitation, or is it just an issue of releasing? If no cavitation, how do you know it's released and do not have a manipulation? Okay, look, sounds can be important. Clicks tend not to be particularly significant. All right. And often what you'll do is you'll set the patient up, it will click before you can thrust it, stop it. All right. You assume a manipulation has been done, you get them up, you look to see what they're like. If they are considerably better, less pain in particular, but probably an increased range of motion, then assume that it's worked. The next time they come in, what you want to know is, how is it now compared to after the manipulation? Now, if it's still good, that manipulation was actually a proper manipulation. If on the other hand, they say, you know, it was okay for an hour or so, and then gradually the pain came back, then what you had was a neurophysiological effect and not a mechanical one. This time when you set them up and you get the same click, ignore it and do the manipulation. Clicks tend to be insignificant. The noises you're interested in are crunches, thuds, noises like china plates going over each other, but more importantly, it's a feeling of movement. Now, I've actually lost hearing in the frequency of manipulative noises. Now, it could be that I'm just not being able to manipulate anymore, but I don't think so. So what I rely on there is a patient talking to me about it, and then me feeling it move. But
it's also good to note that Jim's wife, Sue, has the same frequency in her voice.
Yeah.
So just as a side note, it's just, you know.
Yeah. So that's neurophysiological. It's not neurological, that's neurophysiological. Okay. Yeah, so those clicks, I still don't know what they are, and I don't, there's reasons why I don't accept these as being release of gases, because you relieve the pressure.
I like the retest model. You're going to retest the end feel, and then patient's perception. I mean, yeah, there's a neurophysiological effect of manipulation. So when they come back that second session, my first question, after how you doing, is how long did relief last? If, oh, I'm 80-90% better and I got a little bit that's just left over, I know I had a strong mechanical effect. If the pain, it was good for an hour or 2 or 6 hours, but you know, later on that night, my pain came back and it really hasn't changed that much. Maybe it's 20% better. They're saying the 20% to make me feel better. So I know that was a neurophysiological effect.
Yeah, I mean, there's also the instance where I felt great and I went to bed and I woke up in the morning and it got me again. So something's caused it to come back. That's a whole different animal, and it kept gradually coming back. That's
the mechanical one that readjusted because you went back to the position that caused it.
Yeah. Okay.
And sometimes only the mechanicals too. The classic one is the guy that comes in Friday afternoon, you know, because he's had this thing all week long, you know, he's waited to the last minute. You know, you manipulate it, you treat it, and he doesn't seem any better afterward because neurophysiologically he's probably wound up as well. But that next day and the day after or later that night, he's significantly better. I always kind of consider that there's almost like a delayed mechanical where it takes the tissue and the aggravation a while to kind of go down. I don't know, Jim, if you have any thoughts on what you see with that, but that's a very common patient I see. I just talked to a guy today about it.
Yeah. Yeah, it's this is one of the things we're going to want you to do, if you're not already doing it, and doing it on a fairly frequent basis, is reflecting on your practice. All right, so you look at particularly the cases where you're not happy with your performance at any part of it, and you go back over those cases, you play them over in your mind, and you try to figure what you could have done better. This is reflective practice. Your problem is going to be where you're working now. You see maybe one new patient a day. So if you're just relying on new patients to give you experience, it's going to take you forever to do that. Absolutely it is, because you're not seeing enough. But you could see, and in BC, when I was starting out in Canada, we used to see 60 patients a day. Everybody did, because you was being paid $7 a treatment. So you didn't have much choice. So you got a whole lot of experience very, very quickly. I would say that 3/4 of therapists still remained crap at the end of their career, because what they were seeing of these patients, they was getting the experience. What they weren't doing, though, it wasn't quality experience. So these people weren't reflecting on what was going on. They were doing the same treatments on everybody, pretty much: ultrasound, hot packs, massage, and some half-assed exercise program. They weren't looking at the patient. They weren't looking at what they were doing. So they, over a 10-year period, you could be looking at, well, I don't know, 30,000 people or more. But they was as bad as they were when they started, possibly worse because they forgot anything they'd ever learned in school. So you don't need a lot of time. You don't need a lot of patience. You do need a systematic method of getting quality experience. And then this stuff becomes obvious to you. Like, where do you think this stuff comes from? It only comes from people who've actually thought about what they're seeing. Yeah.
Jim, I have a question for you. For manipulations, cavitations that are successful and you get that good result, the next time they come in, would you say it's so successful if week over week they are, because of their postural activities, because they're sitting at work all day, they're needing the same one? Or would you say if it's successful, they would not need that week over week?
Basically, it's extremely variable. It may have something to do with the underlying instability. These joints sublux because there's an instability underlying it. It's the instability that allows it to sublux. Otherwise, you couldn't do this. So I think a lot of it depends on how badly unstable they are. So, and they lose muscle control. I can manipulate somebody who's had the same problem for 5 years, and a single manipulation can be good, and it'll last 6 months, 8 months. Yeah, with nothing else, no exercises, nothing. Away you go, do it. Or I can manipulate somebody today, and they're good for a week or two, and then bang, they're back in to see me. And that may have nothing to do with what they're doing. So I don't think there's any doubt about this. You manipulate, you have a very strong neurophysiological effect. You activate the stabilizers automatically. You don't have to do stabilization therapy. They're automatically stabilized. And that'll hold for a given time. Then when this is my idea anyway, they'll start to lose their ability to do their job, become inhibited, and away you'll go again the next time they need to come in. And this gets worse and worse. The more often you do this, the worse it gets. So what you've got then is you're doing stabilization therapy. That needs to also be followed up with movement therapy as well. And then there's more of a chance that the stabilizing muscles will continue to work and work appropriately.
Yeah, there's a good article I put into the fellowship section. It's in section 2. I forgot the name of it already. Changes in structure and function of back muscles and lower back pain. I think it complements as well when we talk about these instabilities. And there you'll see they have a nice graph of talking about what the acute back muscle firing patterns are, subacute and chronic. And that guy who keeps coming back and getting sublux, which you may be looking at as a chronic case where he's atrophied or fibrosed at that area. So he's unable to stabilize if it's a lumbar segment. So his way of getting stability is to jam it into extension and sublux the joint. So you're going to always find it. It may not always be painful, but you need to have that, and again, that's where that muscle training portion of it is. That complements what we do. Funny enough is the fastest part of your treatment pattern will be what you learn in this program. The rest of what you do is going to be in that rehabilitation portion, where that next 45 to 60 minutes of your treatment session will be on how do I get this motor control and movement therapy portion of it under control, so that they aren't back here in next week or 4 months or down the ride. So you'll find what we're talking about here complements what's been published in the research on how do you follow up with manual therapy. Does that make sense, Mark?
Yeah, that helps. I appreciate it.
The other thing you can do that actually does work, because patients are not going to comply, all right? 90% of your patients are going to stop doing their exercises pretty much as soon as you discharge them and the pain doesn't come back. And they'll keep doing that. One of the things you can do is stim them. Let them buy a muscle stim, show them how to use it, keep whacking at the muscles with the stim, a couple or 3 times a week. You'll keep those muscles active, and there's less chance of it recurring. You're still going to see them again, obviously, but often they won't even do that. Actually, I'm one of these people. I'm exactly that person. I'll bitch and complain rather than actually do anything about it. But at least you give them another tool. Your job is to give them the exercises. The chances are they're not going to do it, but it's not your problem. Yeah. But the other thing is ergonomics. Yeah, you're absolutely right. If they're doing stuff that is continuously damaging or nudging this joint, then they need to change what they're doing, which is about as successful as having to do a complicated exercise program for the next 8 months.
Pain's a wonderful motivator. So, what I like to do is I find out what is painful and can I positionally relieve it. And it's like running. If you choose to would you choose to sit in a position that's painful or non-painful? The retraining with that can be rather rapid, because given the choice between the two, you're going to pick the one that is non-painful.
You've dealt with athletes, haven't you?
Yep.
Yeah, that work?
It does.
Oh dear.
Also works with sitting and standing and lifting and everything else. So it's really that portion of that movement re-education portion of it, being specific to that individual, identifying if it's okay, they're more of flexion instability or extension instability that you might be
You're
seeing.
basing this on them not coming back and seeing you again, aren't you?
No, they'll come back. They like me.
Yeah, that's my point. They come back because they stop doing it.
Yep.
Yeah.
Okay, I'm okay with that. I'm 100% fine with that, by the way.
Yeah.
If they don't want to do it and come back, I am cool. It is great on the bottom line.
Well, that's the thing, isn't it? You're going to pay your mortgage.
Yeah.
Oh, you've got a lot of questions here.
Again, I pulled them out, Jim, so we can pull them out, and some of those questions we can follow up with if we don't have time to answer all the questions. I copied and pasted them to a Word document.
Yeah. All right. Okay, we're nearly at the end of our time. Anything else? Okay.
Again, two articles I referenced out of there would be the one on the motor control in the lumbar spine. If you have any questions about that or want to do a side discussion, let me know. That's kind of part of the fellowship, but it complements what we're doing here. So Mark, if that's of interest or someone else, just let me know. Okay, and we can start a discussion on the discussion board about that.
All right, guys. So next week, let's have a look. What have you got coming? You've got neuromeningeal test, clinical reasoning, bias and error. Watch that one. If you didn't watch the first clinical reasoning, watch that one with you. And then diagnosis, which is me ranting over for about 10 minutes or so. Okay. All right. I'll see you next Thursday. Take care, everybody. Bye.
Thank you.
See you guys.
Good questions today.